Hello everyone, and welcome to our presentation entitled Mental Health Needs of Treatment-Seeking Children and Youth in Ontario, Canada during the First Pandemic Wave. My name is Jocelyn Van Dyke, and I will be presenting this presentation on behalf of myself, Adya Vasudeva, Dr. Jeffrey Poss, and Dr. Shannon Stewart. The current pandemic has completely altered the daily lives of children and youth, leaving many of them psychologically vulnerable during this time. For example, school and service closures have greatly impacted the daily routines of children. They might also be exposed to frightening news, illness, and death of loved ones during this time. Moreover, with school and service closures, a lot of caregivers are being expected to care for their children for extended periods of time, with limited social supports. This, alongside increased stressors that caregivers might experience, leaves families more vulnerable to increased caregiver stress and negative mental health, which in turn can greatly impact child and youth mental health outcomes. Emerging studies from across the globe are reporting concerning levels of anxiety and depression amongst this population during the first few weeks of government lockdown, resulting in researchers and clinicians anticipating an increase in mental health needs and service utilization amongst this population during this time. However, studies globally are reporting a decrease in children and youth's mental health presentations in psychiatric emergency departments and secondary mental health institutions during the first few months of the pandemic. This decrease may be due to a number of healthcare factors, such as staff relocation to COVID-19 units, heightened clinical threshold for admission, or patient factors such as fear of contracting COVID-19, stay-at-home messaging, and reluctance to burden the healthcare system. It is also possible that there has been an increase in coping strategies and resilience in these families during the pandemic period. To our knowledge, this is the first Canadian study to examine service trends using data from routine assessments at mental health agencies across Ontario. We examined both referral trends and key demographic and mental health outcome variables that might help explain any observed changes in mental health referral trends in our sample. In these unprecedented times, this research is critical in understanding what factors might be contributing to the mental health needs of children and youth and their access to critical mental health services. Routine assessment data was collected from 55 child and youth mental health agencies across Ontario, Canada. Assessments completed during March 1st to October 31st in 2018 and 2019 were compared to the same period in 2020. A total of 47,417 assessments were conducted using either the NRI Child and Youth Mental Health Assessment or the NRI Chime Screener, as described in greater detail on the next slide. So the NRI is an international collaborative organization which provides a seamless, comprehensive assessment system, allowing for the collection of high-quality data which can be used to promote evidence-informed clinical practice and policymaking decisions pertaining to vulnerable persons. The CHIME Full Assessment is a larger 400-item assessment and shares many domains and items with the CHIME Screener. The screener consists of approximately 100 items and takes approximately 15 to 20 minutes to complete. Both assessments are completed using multiple sources of information, such as family members, community members, documents reviewed, and clinical observations, and they are used to evaluate and identify children and youth's mental health needs, risks, and informed care planning. These instruments were also designed to be used in multiple settings, including schools, community programs, as well as inpatient and residential services to support an integrated health information system. Data was collected by trained assessors as part of routine care and de-identified prior to storing on the NRI Canada online system. The University of Western Ontario's Research Ethics Board provided approval for all secondary analyses. Client 3-digit postal codes were matched with the 2016 census information from Statistics Canada to estimate median neighborhood income for children and youth that completed an assessment. So this graph provides information regarding the total number of assessments completed before and during the pandemic. The blue line represents the total number of assessments conducted during any specific month before the pandemic, so they are the average of 2018 and 2019 data from that month. The red line represents the total number of assessments conducted during any specific month during the pandemic, so that would be during the year of 2020. The percentages along the red line represent the percent change in total number of assessments from pre-pandemic to during the pandemic. April and May had the lowest volumes, dropping to an average of 55% from pre-pandemic levels. Overall assessment volume declined by 38%, however. To get more specific, males declined more than females, younger clients declined more than older clients, new clients declined more than clients who had been previously screened or assessed. Clients without English as a first language declined more than those with English as a first language, and assessment volume decline was greatest in lower income areas. Looking specifically at the method of assessment, phone assessments more than doubled, and video assessments increased from almost 0% to 28%, whereas in-person assessments, unsurprisingly, dropped 86% during the pandemic. Now looking specifically at the effective income, this graph represents the average number of assessments per 1,000 children and youth in the pandemic as well as the pre-pandemic comparison period, separated by median neighborhood income. Quartile 1 represents participant data from children living in neighborhoods with average incomes that fall within the lowest 25% of earnings, and subsequently, Quartile 4 represents participant data from children living in neighborhoods with average incomes that fall within the highest 25% of earnings. Therefore, this graph shows a decline in assessments in the pandemic period for all income quartiles and sex groupings. This graph demonstrates the percentage decline in assessment volume per 1,000 persons from the pre-pandemic period to the pandemic period. Males declined more than females in all 4 income quartiles, and those in the lowest income quartile, or quartile 1, showed the greatest percentage decline in assessments. The role of schools and the support students are receiving in school shifted during the pandemic period. For example, in the pandemic period, a higher proportion of students were being homeschooled or in regular classes, and a lower proportion were receiving special support or accommodations. Furthermore, school staff were less likely to be a source of information for the assessment during the pandemic. There was a decline in bullying seen in the pandemic period. Furthermore, among females and overall, but not among males, there was a significant increase in the proportion of children and youth who had witnessed domestic violence during the pandemic period when compared to the pre-pandemic period. Regarding specifically caregiver impacts, there was no significant change seen in the caregiver having an addiction or substance abuse problem during the pandemic period. About 1/4 of the cases reported that their caregiver had experienced a major life stressor in the past 90 days, which was an increase from pre-pandemic data. A significant decrease in the pandemic period in the proportion of caregiver showing distress, anger, or depression was observed. And finally, the most primary caregiver in the child or youth's life showed no significant change in them working or being in school. So moving on to some mental health related outcomes, among females but not among males, there was a higher proportion of risk of self-harm and a higher proportion of depressive symptoms observed. Anxiety was also found to be higher overall. Whereas on the other hand, the proportion of risk of harm to others, destructive behavior, and hyperactivity and distractibility decreased. The following 2 graphs demonstrate 2 clinical profiles month by month during both the pre-pandemic and pandemic periods. This graph shows the proportion of males 11 and under demonstrating high risk for significant aggressive and destructive behaviors. This proportion of males in this category is significantly lower during the pandemic than pre-pandemic. Whereas this graph shows the percentage of adolescent females presenting as at risk for self-harm. Starting in July and later in September and October, the proportion of adolescent females at high risk for self-harm is significantly higher during the pandemic than the pre-pandemic period. Finally, during the pandemic, children and youth were less likely to be involved in an organized club or team program. And furthermore, the proportions of problematic video gaming and problematic internet use was higher. Alcohol use remained low and declined significantly among females, and the proportion of drug use and intentional misuse of prescription or over-the-counter drugs did not change. Though there was an overall increase in anxiety in children and youth, a significant increase in depression and self-harm was seen in females. The present study also demonstrates an increase in females witnessing domestic violence during the pandemic, which is an important risk factor for self-injurious behaviors. Self-harm behaviors are known forms of coping behaviors that help regulate affect responses in social situations, especially amongst girls. Moreover, with the limited opportunities for disclosure of such domestic violence due to school closures and stay-at-home orders, we suspect that the rates of children exposed to such violence is greater than what has been reported. More sedentary activity and lack of access to recreational spaces may be an explanation for why the proportion of children and youth exhibiting hyperactivity and distractibility, risk of harm to others, and destructive behavior declined while problematic video gaming and internet use increased. This is problematic as gaming and internet usage can negatively impact sleep patterns and increase the risk for psychiatric disorders. With lack of access to recreational spaces, children and youth may also be turning to social media as a coping mechanism, which leaves these children more vulnerable to related addictions. There are a number of potential explanations for the observed decline in new referrals observed compared to previously assessed children and youth. Government messaging to stay home and not overburden the healthcare system may have caused hesitancy for people to seek out mental health services. Also, due to the fact that schools were shut down and moved to online during the pandemic, may have played a role in the reduction of new referrals because schools play a critical role in identifying the mental health needs of students and providing access to community service referrals. This also explains why specifically referrals for behavioral issues such as hyperactivity and distractibility that may be more noticeable in the classroom declined. Despite that our study showed a decrease in assessments from low-income neighborhoods, these individuals are shown in various Canadian reports to be more likely to have pandemic-related health and psychological stressors. Perhaps the reason for this inconsistency is that these low-income families may not have the resources to access mental health services online during the pandemic, such as a stable internet, private spaces in the house for appointments, and devices with software to appropriately access services. Another potential reason for this inconsistency is that children within low-income neighborhoods are more likely to rely solely on school to meet their mental health needs when compared to children from high-income neighborhoods. Therefore, the present pandemic might present new challenges that further exacerbate pre-existing inequalities in access to health care for these families and their children. Perhaps this decline in assessment shows that some children and youth are actually experiencing better mental health throughout the pandemic. Our results show that bullying significantly decreased during the pandemic, most likely due to school closures and online schooling. Additionally, children with certain mental health needs, such as social anxiety, may see a reduction in symptoms during this time. Some limitations and future directions for our study. The sample consisted of only Ontario children and youth. The impact of COVID-19 on children and youth's mental health in Ontario may be different in other regions with more or less COVID-19 cases, different government restrictions, and other pandemic-related stressors. The data also only covers the first 8 months of the pandemic, ending in October of 2020. Further research is needed to examine the mental health needs of children and youth over time, as there may be some mental health presentations that do not manifest until later. Our study provides evidence that Ontario, Canada aligns with the incoming literature worldwide, highlighting a decline in children and youth mental health assessments. Furthermore, during the pandemic, there has been an increase in certain mental health concerns and a decrease in others. This provides useful data for mental health practitioners who need to adapt to the changes in children and youth's mental health needs as a result of the pandemic. The clinical implications of these findings support a high-quality standardized assessment, which can improve early intervention, triaging, and the prioritization of mental health services. This can be beneficial at identifying those who are high risk, especially when typical methods of referrals, such as schools, are operating online. The authors have no conflicts of interest to disclose, and if you want to check out our advanced online publication, here's the citation for that. Anyway, thank you all so much for listening to our presentation. We really appreciate it.
Hi everyone, my name is Adya and today I will be presenting on our study titled Impact of the COVID-19 Pandemic on Depression, self-harm, and suicidal behaviors amongst children and youth. This presentation is by myself, my colleague Jocelyn, Dr. Jeffrey Poss, and Dr. Shannon Stewart. So before we start, I just wanted to include a land acknowledgement. We want to acknowledge that Western University is located on the traditional land of the Anishinaabeg, Haudenosaunee, Napawak, and Atawandran peoples on the lands connected with the London Township and Sombra Treaties of 1796 and the District 1 Spoon Convict Wampum. We acknowledge the historical and ongoing injustice that Indigenous peoples, First Nation, Métis, and Inuit endure in Canada, and we expect responsibility as a public institute to contribute towards revealing and correcting miseducation, as well as renewing respectful relationships with Indigenous communities through our teaching, research, and community service. So first of all, I'll just go through some of the background that laid the groundwork for our study. So as a lot of you know, the COVID-19 pandemic has undoubtedly changed the lives of children, youth across the globe, shifting their daily routines and interactions with family, friends, and communities. It is important to note that even prior to the onset of the pandemic, there was an increase in diagnoses of mood disorders and presentations to emergency departments in Ontario related to self-harm amongst older children and adolescents over the last decade. Moreover, in 2019, suicide was the leading cause of death for adolescents ages 15 to 19 years of age and the third for children ages 10 to 14 years old in Canada. Research on past pandemics, natural disasters, and economic recessions have noted concerns for an increase in risk for suicide and self-harm amongst this population during this time. This is due to this increase in social isolation and economic instability. Additionally, periods of school closure in particular might leave children without adequate access to school mental health services and support of the larger circle of adults and professionals, such as teachers and school counselors, that could identify signs of abuse or mental health distress and send these children to the appropriate community resources. However, there are limited current studies examining patterns of changes in depressive symptoms, self-harm, and suicidality amongst children and adolescents during this time. So we were only able to locate 10 studies that examined children and youth's presentations related to depression symptoms, self-harm, or suicide. And these include admissions to hospitals and community mental health agencies. 8 of these that are summarized on this slide were conducted outside of Canada. And overall, as you can see, while there was this general decline in assessment volumes across these different settings related to overall mental health distress, there was no consensus in terms of general trends related to depression symptoms, self-harm, or suicide in this group. So while some studies noted an increase in the proportion of presentations related to these symptoms, others noted a decline. And like I said, this represents the proportion of the total assessment volumes, since the actual N value or number of assessment declined across studies. So what's happening here in Canada? Like I said, there were 2 studies that were conducted in Canada that we could locate. The first one was conducted by the Canadian Institute for Health Information, and this was a report released earlier in 2021, which indicated that emergency department visits and hospitalizations related to self-harm declined for all age groups in Ontario, Alberta, and Yukon during the first wave. So this was from March to September 2020. However, they noted that the proportion of visits and hospitalizations related to self-harm did not actually change during the pandemic period. Moreover, the greatest decline of assessment volume was during March to May, and this is when most COVID-19 restrictions were happening, with some partial recovery in assessment volumes during the summer. The second study we located was our previous study, directly preceding this one, which examined the impact of the pandemic on mental health outcomes within 53 community mental health agencies in Ontario. And we found that during the first wave, so the first 8 months of the pandemic, the proportion of assessments related to self-harm and suicidal behaviors actually did increase. Similar to the ER data, we also noted some partial recovery in assessment volume because the overall assessment volume did decline in our study during the later summer months once some of these pandemic restrictions lifted and some children went back to in-person school. In addition to this limited research, we also could not locate any studies that examine these factors more longitudinally, which is critical since now we've experienced multiple waves of this pandemic. So in this current study, we present a subset of findings from a larger longitudinal investigation that we're conducting in Ontario, evaluating the mental health referral trends and presentations of children and youth accessing mental health services across 53 mental health agencies. And these mental health agencies represent about 70% of agencies providing such services in Ontario. In this study, specifically, we examined changes to child and adolescent presentations that were related to depression, self-harm, and risk of suicide throughout the first two pandemic waves. So now we'll go through the method that we used. So in this study, like I said, we looked at child and youth mental health presentations in Wave 1 and Wave 2. Wave 1 comprised of all assessments conducted in the months of March through June 2020, and this was compared to March and June of 2019. And then Wave 2 was comprised of assessments which were obtained from months of September 2020 through January 2021, which was then compared to assessments completed from September 2019 to January 2020. So our assessment data during the waves was compared to 1 year prior equivalents. We also compared assessments in each wave to each other, so Wave 1 to Wave 2. And these wave boundaries were similar to other COVID-19 investigations in Ontario. We purposely chose to exclude the months of July and August when COVID-19 cases, as seen on this graph in the screen, were low, and students regularly do not attend school during this time, irrespective of COVID shutdowns. The assessment data for our study was obtained from the Intra CHIME assessment tool, the Intra CHIME DD, and the Intra CHIME screener, which I will describe in greater detail in the next slide. And data from these assessments were obtained as a part of regular clinical practice at the select mental health agencies. So in the study, we had a total of 35,162 assessments, 21,121 in the pre-pandemic period, and then 14,033 during the pandemic period. Significance testing was conducted during the pandemic waves and their equivalent pre-pandemic 1 year prior periods, as well as between Wave 1 and Wave 2 using chi-square tests. Furthermore, we also obtained the first 3 digits of the child's postal code, which was then linked to provide neighborhood median household income information. So the measures themselves, the Intra is an international collaborative organization which utilizes a comprehensive assessment system, and this assessment system allows for evidence-based, high-quality data to be collected and used to inform clinical practice and policy decisions as they pertain to vulnerable populations. So the Intra Child and Youth Mental Health Assessment is a 400-item tool used in child and youth populations to obtain data-driven picture of the individual's mental health needs. Trained assessors complete this comprehensive assessment by consulting with multiple sources of information. So this includes the child, caregivers, teachers, clinicians, and any available medical and educational records. Psychometrically sound skills and algorithms are embedded within this instrument to support clinicians in identifying the child's strengths, areas of need, and then inform care planning. The Intra CHIME screener is a smaller 99-item assessment which complements the CHIME full assessment, and this instrument aids assessors by assisting them in decisions related to triaging, placement, and service utilization. It just provides a brief snapshot of the child's level of functioning and helps clinicians determine if a more comprehensive assessment is needed. Lastly, the Intra, CHIME, and Developmental Disability Assessment, or the CHIME-DD, is to be used with children and youth with developmental disabilities. And similar to the full CHIME, it provides a comprehensive, standardized, and empirically supported mental health measure to support comprehensive care planning, outcome measure, quality indicators, and case mix classification to estimate relative resource intensity. So like I said, there are many skills and algorithms embedded in this instrument, but the two that we looked at for this study in particular were the risk and the DSI algorithms. So the risk of suicide and self-harm in kids algorithm assesses various pieces of information about the child, such as the child's attempt to kill self, self-harm without attempt to kill, consideration of self-injury, others being concerned about self-injury, families feeling overwhelmed, and any self-injurious behaviors. While the DSI measures depressive symptoms in children and youth related to sad or pained facial expressions, negative statements, self-deprecation, guilt or shame, and hopelessness. So what did we find? Well, as you can see in this figure here, there was a relative change in assessment volumes for each month as compared to 1 year prior. During wave one, we saw this sharp decline of over 50% in assessment volumes, with some partial recovery of assessment volumes, so only a 20% decline when in-person learning returned for some students in September. But again, there was a decline of 45% of assessment volumes in January, when almost the entire province went into shutdown again. When looking at our specific algorithms, we noticed when looking at wave one and wave two, compared to the previous year, both waves showed an increase in the proportion of children and youth presenting in the mental health system with risk of suicide and self-harm behaviors, as well as depressive symptoms. Wave two in particular showed this increase in self-injurious attempts in the last month. And when comparing the two waves, wave two showed a significant increase in the proportion of children and youth presenting with depressive symptoms and self-injurious behaviors. And these findings remained consistent even when adjusting for age, sex, neighborhood income, and first encounter with service agency. Lastly, as you can see in this figure, we actually did note some of the greatest changes in adolescent females with depressive symptoms and risk of suicide and self-harm. When dividing it by the income quartile, those in the upper two income quartiles, so representing quartile one would be the highest 25% income in Ontario. The top two income quartiles noted the most significant increase in depressive symptoms and the risk algorithm. So moving on to our discussion, firstly in our study we noted the substantial decline in assessment volumes, and it is important to note the critical role that schools and primary care settings play in identifying and meeting children's mental health needs. And primary care physicians and teachers are often the first professionals that either identify a mental health need or that parents consult when they have concerns about a mental health need of a child. Experience of child maltreatment and abuse, which are also associated with internalizing and externalizing symptoms, might also go underrecognized during this time, as school personnel play a critical role in identifying children who are experiencing or at risk for abuse or neglect. And even though schools did reopen for the majority of the second wave in this study, and primary care settings did continue to operate using some form of mixed model engagement, where parents did have the option of bringing in their child if needed for checkups, while most checkups happened online. Parents and younger children and adolescents might have been hesitant to access certain services in periods of lockdown just due to fears of contracting the virus, or even public health messaging discouraging people to access in-person services. Lastly, like all studies, we also do have our fair share of limitations. Firstly, it's important to note that depressive symptoms, self-harm, and suicidal behaviors are complex concepts, and data entailed in this study only consists of treatment-seeking children from select mental health agencies within Ontario. This data cut also only represents data from the first two pandemic waves, prior to the administration of vaccines. So therefore, these studies might not be representative of regions with different COVID-19 infection rates and pandemic-related restrictions, and future research is needed to examine these trends across different settings, as well as once the pandemic subsides. Overall, this study does point towards the need for standardized evidence-based assessment measures that can be administered across settings and are easily transferable to online access for clinicians. Additionally, supporting parents and teachers during this time is of utmost importance. For example, Children's Mental Health Ontario online has some really good resources for professionals working with children as well as parents to help them identify mental health distress during this time and refer children to the correct resources. So that wraps up our presentation. Thank you so much for attending. The last couple of slides are just our references.
Hi there, my name is Angela Celebri, and the title of my research work is An Examination of Abuse, Mental State, and Health Factors Pre and During the COVID-19 Pandemic Among Clinically Referred Adolescents in Ontario, Canada. I completed this work alongside Shannon Stewart, Ashley Tooley, and Jeff Poss, and we're excited to share it with you at the Joint Mental Health Research and Innovation Day. The COVID-19 pandemic continues to have a wide-ranging impact on the well-being of children, youth, and families around the world. When COVID-19 was first declared a pandemic by the World Health Organization in March 2020, governments began putting emergency measures in place to stop the spread of the virus, which included a number of closures. These closures have caused major disruptions to daily routines and widespread social isolation, which can both have a significant impact on mental health. While a growing body of research shows that the pandemic and associated restrictions have led to increased mental health problems and psychological distress among adults, studies examining the impact on adolescents are scarce, which is concerning because they represent a particularly vulnerable population. Recent research has begun to explore the impact of the pandemic from the perspective of adolescents. Some of the most common challenges reported among this age group include interrupted in-person interaction, which has impacted their ability to socialize and feel emotionally supported by their peers. Stay-at-home restrictions, which has limited their ability to participate in activities outside of the home with family and friends. Lack of privacy and personal space, along with COVID-related angst, being in a funk, and stress related to school. Having said that, adolescents have also highlighted some of the positive aspects or benefits of the pandemic, which include spending more valuable time with family, experiencing more quality time to focus on themselves, for example, to exercise or just slow down and relax, as well as improving friendships, for example, by the pandemic testing and proving these relationships. Although in its infancy, research has also begun to examine the impact of the COVID-19 pandemic on the mental health of adolescents. A systematic review found that adolescents from different countries around the world generally reported heightened stress, anxiety, and depression, as well as increased use of alcohol and cannabis during the pandemic. However, a few studies have found either no difference or an improvement in mental health symptoms during the pandemic. Furthermore, some research has found a differential impact among certain subgroups. For example, one study found that the impact of the pandemic on adolescent mental health differed based on the level of mental health problems before the pandemic. More specifically, young persons who had worse than median mental health before the pandemic experienced a decrease in hyperactivity, conduct problems, peer relationship problems, and emotional problems, but an increase in the pro-social tendency during the pandemic. However, young persons who had better than median mental health before the pandemic, experienced changes in the opposite direction. Studies like this highlight the fact that the negative impact of the COVID-19 pandemic on adolescent mental health is not universal, and that there's likely a myriad of factors that need to be considered in order to understand the nuanced effects on different subgroups within this vulnerable population. The aim of the current study was to examine the impact of the COVID-19 pandemic on the mental health and well-being of adolescents previously referred to secondary mental health agencies. A longitudinal design was utilized to compare a vast array of variables pertinent to adolescent mental health prior to and during the pandemic. We also utilized area-based measures of income to examine the relationship between socioeconomic status and pandemic-related changes. While the literature has generally shown an increase in mental health symptoms and health-compromising behaviors among adolescents during the pandemic, notable differences have been reported among various subgroups. Given the inconsistent findings regarding mental health implications for treatment-seeking adolescents, the current study was exploratory in nature. Data were obtained from assessments of individuals aged 12 to 18 years accessing mental health services in Ontario, Canada. The sample included those assessed with the Intra Child and Youth Mental Health Assessment and Adolescent Supplement between March 17, 2019 and March 16, 2021. The sample was divided into two time periods: a pandemic year beginning March 17, 2020, the date Ontario declared a state of emergency as a result of the novel coronavirus, and a pre-pandemic year exactly 1 year prior. There were approximately 8,500 assessments completed in total, which included just under 4,000 assessments during the pandemic year and just over 4,500 assessments in the year pre-pandemic. Individuals could be assessed in both years, as well as more than once in a given year. The rationale for using all assessments was that this best represents the flow of cases into these organizations in a consistent way over both years of interest. The Intra CHIME is a comprehensive, clinician-rated, standardized, and multi-sectoral mental health instrument for children and youth. It includes over 400 items and builds a comprehensive picture of the child's strengths, needs, functioning, and areas of risk to inform care planning for clients with mental health needs. The clinician creates a clinical profile based on a collection of reports, observations, and judgments made from interactions with the family, the child or youth themselves, and service providers with appropriate consent. A number of algorithms and scales are embedded in the CHIME to indicate the level of risk based on symptom frequency and severity. The Intra-Adolescent Supplement is integrated into the CHIME and completed for all youth who are 12 years of age or over, or those under 11 years of age if they're engaging in more mature behaviors, for example, illicit drug use. The CHIME was administered as part of typical practice from 35 agencies across Ontario. All assessors completed a 2.5-day training session regarding how to administer and score the CHIME. The service providers that administer the CHIME ranged in discipline and expertise and included psychologists, nurses, psychiatrists, speech and language therapists, child and youth workers, developmental social service workers, and social workers. All data collected is entered into a de-identified web-based software, password protected, encrypted, and stored on computers with no internet or USB ports to ensure confidentiality. This web-based software securely stores the data at Intra Canada and provides each case a randomly assigned study-specific participant number. Given there were fewer assessments in the pandemic year, and because this decline differed, notably by sex, a corrective weight was applied to the pandemic year to adjust for the likelihood of selection. We chose to combine age, sex, and area income quartile, and use this as a classification from which weights were assigned to cases in the pandemic year equal to the inverse of their likelihood of selection compared to the year prior. Given that this would not normally be expected in a year-over-year sample, it's likely that the pandemic conditions themselves influence the likelihood of client selection. As such, the demographic and area income variables that were available were used to correct this. We examined both the unweighted and weighted samples for differences between the 2 years, using chi-square tests for dichotomous and categorical variables, and t-tests for the continuous variable of h. The following table provides proportions of a variety of characteristics in the pre-pandemic and pandemic year, as well as the proportion in the pandemic year that reflects an adjustment for age, sex, and neighborhood income. All tests of significance use chi-square tests, with adjusted p-values adding calculated weights based on the inverse likelihood of selection in the pandemic period. Comparisons from pre-pandemic data and pandemic data revealed no increase in incidence of witnessing domestic violence, nor experiencing physical, sexual, or emotional abuse. Further, risk of self-harm and suicide, anxiety, and depression remain the same among our sample of clinically referred youth. Furthermore, with respect to health-compromising behaviors, results demonstrated no increase in problematic video gaming or internet use, or disordered eating, and a decrease in cannabis use and alcohol intoxication. The purpose of the current study was to add to a growing body of literature examining the impacts of the COVID-19 pandemic on adolescents' health and well-being and health-compromising behaviors. Our results demonstrated no increase in the risk of harm to self or others, anxiety, or depressive symptoms. These findings are consistent with previous findings demonstrating that those adolescents with poorer than average mental health prior to the COVID-19 pandemic experienced a decrease in a variety of mental health indicators and an increase in prosocial tendency during the COVID-19 pandemic. It's also possible that participants of the current study have previously received one or more forms of mental health support, such as psychotherapy or psychopharmacological, and thus already have needed services resulting in improved coping to manage changes brought on by the pandemic. We also found no increase in disordered eating habits or problematic video gaming and internet use. Previous COVID-19 pandemic findings have demonstrated a link between the use of video games as a coping strategy and increases in depression and anxiety. Among our sample, we saw no change in problematic video gaming or depressive symptoms. Our findings also showed a decrease in cannabis use and alcohol intoxication. Notably, other research has also found a decrease in substance use during the pandemic. It's been suggested that a potential unintended benefit of the pandemic might be that factors associated with social distancing, lockdowns, and reduced peer contact may act as a protective factor against engaging in substance use with peers. Emerging research outlining the mental health impacts of the COVID-19 pandemic on children and adolescents has varied, with some findings indicating significant negative impacts and others finding little or no negative impact of the pandemic. These mixed results suggest that children and adolescents at different mental health stages may experience the pandemic differently and thus have different mental health needs. It's also possible that given the higher prevalence of mental health issues in adolescence as compared to childhood, there may be more room for improvement among adolescent samples than among samples of children, particularly in those accessing mental health services. Furthermore, emerging research findings have underlined that certain subpopulations, including Black children, children with developmental disabilities, as well as those from ethnically diverse backgrounds, are at heightened risk for negative mental health sequelae during the pandemic. Findings from the current study demonstrate that for clinically referred adolescents, restrictive COVID-19 pandemic measures, such as virtual learning and home confinement, may act as a protective factor against worsening mental state indicators and health-compromising behaviors during the adolescent years. This has significant implications for care planning for youth seeking mental health treatment. Taken altogether, our findings underscore the importance of understanding the nuanced impact of the pandemic on various subgroups of children, youth, and families. Given the COVID-19 pandemic is still ongoing, these findings highlight the need for continued monitoring of outcomes for these children and youth longitudinally to determine the long-term impacts of the pandemic on the mental health needs of this vulnerable population. The following is the list of references, and I would just like to say thank you so much for listening to this presentation.